1, 2,
And review, somebody female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the phone.
It's, charter
300 please.
I'll keep you on again.
Pulse check. No pulse.
No more pulse.
Yeah. Here, what are the echo people get? And her blood pressure is off the property.
45 minutes of CPR and no return of circulation. Okay.
In most areas of clinical medicine, there's this expectation of, well, absolute crystalline precision. You know, like you think about orthopedics, for example.
Right.
A patient comes in, they've had a fall, you get an x-ray, and boom, there it is. A jagged white line across the radius. The pathology is contained, the intervention is super clear, the problem is fixed. It's very binary.
Yeah, it's deeply comforting when medicine works that way. You identify the structural failure and you repair it. But when you step into obstetric nursing, and specifically into the postpartum period, that binary framework just completely shatters.
Exactly. You are suddenly navigating this clinical landscape that is the definition of diagnostic muddy waters.
Yeah.
And today, we're taking a deep dive into the puerperium, or what we now commonly call the fourth trimester.
Right. And for you listening, we're acting as your clinical mentors today, your exam coaches. We are not going to read a textbook at you. We're aggressively applying the 80-20 rule here.
Yes, the Pareto principle.
Exactly. We are sifting through all this massive postpartum data to give you the exact concepts, the patterns, the high-yield facts that will give you 80% of your exam value. We want to make you a safe, critical thinking nurse.
Because the stakes here are incredibly high. Postpartum isn't just a quiet recovery phase where, a patient just rests with a newborn. It is a highly volatile, systemic biological transition.
It really is. The body just ran a 9-month marathon, right? It fundamentally altered its cardiovascular, endocrine, and musculoskeletal systems to gestate a human being. And then abruptly, the placenta detaches.
Yeah, it's the equivalent of a massive manufacturing plant that's been producing one highly specialized product for 9 months, and then overnight, without a single moment of shutdown, it has to completely retool its entire production line.
That abrupt retooling is exactly where the danger lies, because the machinery doesn't always transition smoothly. We're talking about massive, rapid fluid shifts, extreme hormonal crashes, and a highly condensed window where hemorrhage or systemic infection can just turn fatal incredibly quickly.
Right. The expectation is that the patient is simply tired from labor. But the reality is their body is executing a deeply precarious physiological tightrope walk.
Which is why our goal for this deep dive is to isolate those high-yield clinical realities, the specific patterns, the counterintuitive findings, and the absolute priorities that actually keep patients alive.
So let's start with the most immediate threat in that transition. Maternal safety is our #1 priority. And postpartum hemorrhage is the absolute apex predator here.
Oh, without a doubt.
And to understand how a hemorrhage is prevented, we have to look at the mechanics of how the uterus reconstructs itself. We throw around the term involution, but the sheer physics of what the uterus does is just hard to wrap your head around.
It's an aggressive biological teardown. Involution is the process by which the uterus returns to its non-pregnant state. And it relies on 3 distinct mechanisms running simultaneously.
Okay, lay those out for us.
First, you have the mechanical aspect. That's the contraction of the myometrial muscle fibers. Second is catabolism, which is the cellular breakdown of the enlarged muscle cells. And third is the regeneration of the uterine epithelium from the lower layer of the decidua.
I really want to unpack the catabolism aspect because the scale of tissue breakdown is staggering.
Mm-hmm.
I mean, immediately post-birth, the uterus weighs roughly 1,000 grams.
Right, about 2.2 pounds.
And it has a volume of about 5,000 milliliters. But over the next 6 weeks, it shrinks down to roughly 50 grams. It goes from the size of a large watermelon to the size of a small pear.
It's incredible.
But where does all that physical mass actually go? The tissue doesn't just vanish.
Yeah.
How does the body process what is essentially 2 pounds of rapidly degrading muscle without triggering massive systemic toxicity?
That's a crucial point, and a process we often gloss over in nursing school. The body doesn't actually destroy the cells and leave the debris lying around. The individual myometrial cells themselves don't entirely die off in massive numbers. Yeah, rather, the hypertrophied cells undergo an intense enzymatic breakdown of their internal protein structures. The proteolytic enzymes within the cells digest the excess protein material.
Wow.
And this massive volume of broken down protein is then absorbed into the maternal bloodstream and eventually processed and excreted by the kidneys. It's a massive metabolic load.
So the kidneys are essentially filtering out the disassembled scaffolding of the pregnant uterus. That is wild.
Precisely. And while that microscopic teardown is happening, you have the macroscopic mechanical tracking. Clinicians track involution physically by measuring fundal descent.
Right, checking the fundus.
Exactly. The fundus, the top rounded dome of the uterus, should sit right around the level of the umbilicus immediately after delivery. From there, the descent is highly predictable. It drops about 1 centimeter or 1 fingerbreadth per day.
And what's the milestone we're looking for there?
By day 10, that entire massive organ has descended back deep into the true pelvis and should no longer be palpable abdominally. If you can feel it on day 12, something is wrong.
Okay, so tracking it from the outside gives us one data point. But tracking the internal healing requires monitoring lochia. And this is where the clinical picture requires some nuance. We have 3 distinct stages: rubra, serosa, and alba.
Right, and for exams, you must know these in order.
Exactly. But it isn't just about color matching, right? It's about understanding the cellular composition of the discharge to determine if that internal wound is healing.
Yeah, let's visualize what's happening inside. When the placenta separates, it leaves behind an exposed, highly vascular wound site the size of a dinner plate.
A literal dinner plate.
Yes. So lochia rubra is the immediate aftermath. For the first 3 to 4 days, the discharge is deep red because it's heavily composed of pure blood from that placental site mixed with tissue debris.
And then as the underlying vessels begin to seal, the composition shifts, right?
Exactly. By day 3 or 4, it transitions to lochia serosa.
So the active bleeding is fundamentally stopping, and the discharge is now driven by the inflammatory and healing response.
Right. Serosa is a pinkish-brown, more watery fluid. It's heavily populated with leukocytes, white blood cells rushing to the site, along with decidual tissue and cervical mucus. This lasts until about day 10.
And then the final stage.
Finally, as the regeneration nears completion, you see lochia alba. It's creamy white or light brown, consisting almost entirely of leukocytes and epithelial cells. This stage can linger for several weeks.
Okay, so the progression is strictly linear, rubra to serosa to alba. If it ever reverses, like if a patient who has been in the serosa phase suddenly experiences a return of bright red rubra, that is an immediate red flag.
Yes. High-yield exam priority right there.
It means the structural integrity of the healing placental site has been compromised. But that brings us back to the primary mechanism of hemostasis. I mean, when you have a dinner plate-sized wound inside a highly vascular organ, how does the body stop the patient from bleeding out before those microscopic healing processes can even occur?
It relies entirely on mechanical compression. We are so used to thinking of clotting cascades as the primary way bleeding stops. But in the postpartum uterus, clotting is secondary.
Wait, really? Clotting isn't the main factor?
Not initially, no. The primary mechanism is the unique structure of the myometrial muscle fibers. They are arranged in a figure-8 pattern around the blood vessels that supply the placenta.
Well, that's fascinating.
Yeah, so when the uterus contracts, those muscle fibers clamp down with immense force, acting as living tourniquets that literally crush the open vessels closed.
Which perfectly explains why uterine atony is the leading cause of postpartum hemorrhage. If the uterus is boggy, if it lacks that severe muscular tone, those figure-8 fibers just relax, the natural tourniquets release, and the vessels open right back up into the uterine cavity.
And given the blood flow to a term uterus, a patient can lose a lethal volume of blood in a matter of minutes.
So that is the biological reality we are monitoring. We expect to feel a fundus that is midline and firm to the touch, often described as feeling like a hard grapefruit. A boggy, soft uterus is a blaring siren.
Absolute priority intervention. But let's talk about a counterintuitive clinical reality here, because this frequently trips up even experienced clinicians, and it's a huge exam trap.
Oh, let's hear it.
It's about afterpains. Those are the intense uterine cramps that occur as the organ works to maintain that tourniquet effect. Now, there's this persistent assumption that a Primiparous patient, someone having their first baby, will experience the most severe pain.
Right, because they haven't been through it before. Their body's experiencing this trauma for the first time.
Exactly, that's what everyone thinks. But the physiology dictates the exact opposite.
Really? Why is that?
It's a fundamental misunderstanding of muscle physics. A primiparous uterus has excellent, pristine muscle tone. It clamps down once, forms a tight, hard sphere, and generally stays that way without requiring intense, continuous effort.
Oh, I see.
But a multiparous uterus, one that has been distended and stretched over the course of multiple pregnancies, has lost some of that intrinsic elasticity. It struggles to maintain that firm contraction. Therefore, it has to undergo repeated, violent, spasmodic cramping just to maintain the required tone.
So the pain isn't a sign of failure. It's a sign of a compromised muscle working in massive overdrive to keep the patient safe. And breastfeeding amplifies this exponentially, right?
Yes, big time. Because of the neuroendocrine loop, nipple stimulation triggers the posterior pituitary gland to release massive amounts of endogenous oxytocin that directly targets the oxytocin receptors in the myometrium, forcing it to contract even harder.
A multiparous breastfeeding patient is experiencing a barrage of chemical and mechanical forces that can cause excruciating pain. Anticipating that and managing it aggressively with scheduled analgesics is a vital part of our nursing care. So we know the mechanics of a firm uterus. What happens when we assess a patient, press on the abdomen, and instead of a hard grapefruit, the uterus feels like a soft sponge? What is the immediate, non-negotiable physiological intervention?
The intervention is bimanual fundal massage. Do not pass go. Do not call the doctor first. You massage that fundus.
And you have to understand the physics of what you're doing, right? You're not just rubbing the skin.
No, not at all. You must place one hand just above the symphysis pubis to stabilize the lower uterine segment. This prevents you from physically pushing the entire organ out through the vaginal canal, which is a catastrophic event called uterine inversion.
Yikes, that sounds horrifying.
It is. So stabilize with one hand, and with your dominant hand, you firmly massage the fundus. The mechanical agitation forces the smooth muscle to react and contract. You literally squeeze the muscle until it wakes up and reestablishes those figure-8 tourniquets.
And then what?
Only while maintaining that manual compression do you call for backup and anticipate chemical uterotonics like intravenous oxytocin to sustain the contraction.
Okay, so that's the acute emergency. But what if the uterus remains boggy, or it shrinks initially, but then just stops descending in the days that follow? That's subinvolution. The machinery stalls.
Right. And subinvolution is usually driven by one of two physical barriers. This is a classic exam question. The first is retained placental fragments.
Even small ones.
Even a tiny microscopic cotyledon left adhered to the uterine wall acts like a wedge holding a door open. The muscle simply cannot clamp down completely flush against itself if there is tissue in the way.
Wow, so the smallest fragment can cause massive bleeding. What's the second barrier?
The second barrier is infection, like endometritis. Inflammation causes severe tissue edema, which functionally prevents the muscle fibers from achieving maximum contraction.
It's fascinating how mechanical it all is. But, those mechanics don't exist in a vacuum. A uterus that is actively bleeding heavily impacts the systemic cardiovascular system. Let's look at the hidden clues of cardiovascular shifts. The maternal body just spent 9 months building an incredibly specialized vascular environment, right?
Mm-hmm.
Blood volume increases by up to 50% during pregnancy.
Yeah, that volume expansion is nature's preemptive strike against the anticipated blood loss of delivery.
Mm-hmm.
The body expects trauma, so it stockpiles reserves.
Right.
During a routine vaginal birth, a patient loses an average of 500 milliliters of blood. In a cesarean, that number easily reaches 1,000 milliliters, but the body is holding on to liters of extra volume. In the immediate postpartum period, the cardiovascular system has to aggressively offload that excess, otherwise the patient would go into rapid fluid overload and congestive heart failure.
I want to break down the hemodynamics of that first 48 hours, because it explains why our standard vital sign parameters become temporarily obsolete. We know that right after delivery, cardiac output actually spikes. Why would the heart pump harder immediately after the physical exertion of labor has ended?
It's a phenomenon called autotransfusion.
Okay, autotransfusion.
Oh, yeah. When the placenta delivers and the uterus rapidly clamps down, it immediately redirects roughly 500 to 750 milliliters of blood that was perfusing the uteral placental circuit straight back into the maternal systemic circulation.
Oh, wow. just a massive wave of blood returning.
Exactly. And simultaneously, the relief of inferior vena cava compression, because that heavy uterus is no longer pressing down on the major vessels, causes venous return from the lower extremities to surge. The heart is suddenly hit with a massive wave of returning volume.
So cardiac output remains elevated for those first few days simply to manage the traffic jam of returning fluid. It's pushing all that fluid to the kidneys for diuresis.
Exactly. And because stroke volume, the amount of blood pumped with each beat, is so high due to that increased volume, the heart doesn't need to beat as fast to maintain perfusion.
Oh, so that explains it.
Yes. This is why a mild bradycardia, a heart rate of maybe 50 or 60 beats per minute, is a completely expected physiological adaptation in the early postpartum days.
Which brings us to one of the most critical clinical realities regarding vital signs. Because bradycardia is expected, any instance of tachycardia, a heart rate over 100 beats per minute, should trigger an immediate high-alert investigation. I've seen clinicians write off a heart rate of 115 as just, anxiety from having a new baby or pain from an episiotomy.
That assumption is incredibly dangerous. It's a huge pitfall. Tachycardia is the cardiovascular system's absolute first compensatory mechanism for hypovolemia. Before the blood pressure ever drops, the baroreceptors in the aortic arch detect a decrease in circulating volume from active internal bleeding. The sympathetic nervous system kicks in, ordering the heart to beat faster to circulate whatever volume is left to protect the brain and vital organs. Tachycardia is not anxiety. Tachycardia is hemorrhage until definitively proven otherwise.
You mentioned blood pressure just now. Waiting for hypotension to diagnose hemorrhage is a fatal error, isn't it?
Oh, absolutely. Because of that massive 50% increase in pregnancy blood volume, a postpartum patient can lose a staggering amount of blood, sometimes up to a third of their total volume, before their blood pressure finally crashes.
Wow.
If you wait for the systolic pressure to drop into the 80s, you have missed the window for early intervention. They are already in uncompensated hypovolemic shock.
And on the flip side of that, an elevation in blood pressure is equally sinister. A patient presenting with a sudden spike in blood pressure, especially if accompanied by a headache or visual disturbances, isn't just stressed. We have to consider postpartum preeclampsia.
Yes. The pathology of preeclampsia, the endothelial dysfunction and mesospasm, does not magically vanish the moment the placenta is delivered. It can emerge, or re-emerge, up to 6 weeks postpartum. A high blood pressure reading requires immediate neurological assessment and evaluation for magnesium sulfate therapy to prevent seizures.
There's another layer to this cardiovascular puzzle, and it's the coagulation profile. The body just created a massive open wound, and while the uterus is mechanically clamping down, the blood chemistry itself radically alters to prevent exsanguination.
Right. The pregnant body enters a hypercoagulable state. It significantly ramps up the production of clotting factors, particularly fibrinogen, and simultaneously depresses fibrinolysis, which is the system that breaks down clots. The body is essentially turning its blood into a thicker, highly coagulable substance, and this state persists for 2 to 3 weeks postpartum.
It's an evolutionary survival mechanism that kept our ancestors from bleeding to death in childbirth. But in a modern clinical setting, it's a double-edged sword that introduces a severe new vulnerability.
Yeah, absolutely. Because you have thick, clot-prone blood, and you combine that with a patient who is lying in bed recovering from a grueling labor, experiencing venous stasis, it creates a perfect storm for venous thromboembolism.
Right.
The risk of developing a deep vein thrombosis or a fatal pulmonary embolism is astronomically higher in the postpartum period than at almost any other time in a person's life.
This directly dictates our nursing interventions. If a patient just had a complicated delivery, the human impulse is to tell them to stay in bed, rest, and let us bring the baby to them. But the physiological reality demands the exact opposite.
Early and frequent ambulation is non-negotiable. We medicate their pain, we provide physical support, but we get them out of bed and walking as soon as their motor function allows. Ambulation forces the calf muscles to contract, which acts as a peripheral pump, pushing that thick, sluggish venous blood back up to the heart and preventing it from pooling and clotting in the deep veins of the legs.
We also have to be very careful about how we interpret lab values during this fluid shift. Let's look at the hematocrit. Because the body is dumping so much plasma volume through diuresis, the remaining blood becomes more concentrated. We should expect the hematocrit percentage to stay stable or even rise slightly, right?
Correct. Exam trap alert right here. If you look at a complete blood count and see an acute, significant drop in the hematocrit level, you cannot chalk it up to normal hemodilution. The plasma is leaving the body.
If the ratio of red blood cells is dropping precipitously, it means whole blood is actively escaping the vascular system. It is a laboratory confirmation of hemorrhage.
And the white blood cell count presents a similar diagnostic challenge.
How do we differentiate between the physiological stress of birth and an active, brewing systemic infection?
We know that the sheer physical trauma of labor triggers a massive inflammatory response. It is completely normal for the white blood cell count to spike to 25,000 or even 30,000 in the first 4 to 6 days postpartum.
Which is huge.
Yeah, this leukocytosis makes the WBC count virtually useless as a primary indicator of infection in those early days.
So what parameter do we rely on? The temperature.
Yes, but with a major caveat. The exertion of labor and the resulting mild dehydration will commonly cause a transient fever. A temperature up to 100.4 degrees Fahrenheit, or 38 degrees Celsius, is entirely expected within the first 24 hours.
Okay, so first 24 hours, mild fever is okay.
Exactly. The clinical threshold for diagnosing an actual postpartum infection, like endometritis or a severe wound infection, is a temperature greater than 100.4 that occurs after the first 24 hours, or a fever that persists for 2 consecutive days.
So if we step back and look at the cardiovascular system, it's executing a highly controlled, intentional crash sequence. It is purposefully dumping massive volumes of water while simultaneously thickening the blood and ramping up inflammation. It's a miraculous balancing act, but if one parameter slips, if the tachycardia is ignored or the temperature is misread, the system fails.
Which is why the continuous accurate assessment of these vital signs and really understanding the unique physiological state driving them is the most crucial aspect of postpartum nursing.
That brings us perfectly to the mechanics of that fluid offloading. We know the body is aggressively dumping plasma volume. That fluid has to exit the body, which puts an unbelievable strain on the urinary system.
Oh, postpartum diuresis is extreme. A patient can easily produce up to 3,000 milliliters of urine per day in that first week.
Wow.
This is driven by several rapid physiological withdrawals. During pregnancy, high levels of estrogen and progesterone cause the body to retain sodium and water. When the placenta delivers, those hormone levels crash, taking the sodium retention with them.
Right. And what about the IV fluids from labor?
Exactly. Plus the synthetic oxytocin we use to induce or augment labor or prevent hemorrhage that has a strong antidiuretic effect. When we turn off that IV drip, the antidiuretic effect vanishes and the kidneys just open the floodgates. But the body isn't just producing urine. The bladder has to successfully store and evacuate it. And this is where the trauma of birth creates a dangerous bottleneck.
The bladder and the urethra endure severe physical trauma during a vaginal delivery. As the fetal head descends through the pelvis, it physically crushes the bladder and the urethra against the symphysis pubis.
Which sounds incredibly painful.
It causes intense localized tissue edema and hyperemelemia. Furthermore, if the patient received regional anesthesia, like an epidural or a spinal block, the neural pathways that signal bladder fullness are completely numbed.
So you have a patient whose kidneys are rapidly filling the bladder with thousands of milliliters of fluid, but the tissues are swollen and the brain has no idea the bladder is full.
Exactly. It leads directly to profound urinary retention. The bladder just keeps stretching and expanding.
And this isn't just an issue of patient comfort. An overdistended bladder is a direct, immediate threat to the structural integrity of the uterus we discussed earlier. Let's trace the anatomy of why that happens. The bladder sits anterior to, right in front of, and slightly below the uterus. When the uterus is empty and trying to involute, it relies on the supportive structure of the pelvic floor and the uterine ligaments to hold it in a central midline position where it can contract evenly. But if the bladder fills up and balloons outward, it physically lifts the uterus out of the true pelvis and pushes it upward.
And it almost always pushes it to the right side of the abdomen. Why the right side specifically?
Because the descending colon takes up the space on the left side of the pelvis. So the displaced uterus is forced up and to the right. But the critical issue isn't just the location, it's the physics. When the uterus is pushed up and laterally displaced, the uterine ligaments and the myometrial muscle fibers themselves are severely stretched.
And a stretched muscle cannot contract effectively.
Exactly. The displacement literally prevents those figure-8 tourniquets from clamping down on the bleeding vessels.
So urinary retention leads directly, anatomically, to uterine atony and postpartum hemorrhage. A full bladder can kill a patient just as quickly as a retained placenta.
Which is why assessing the bladder is inextricable from assessing the fundus. If you palpate a soft, boggy uterus, and you note that it is located high above the umbilicus and deviated to the right, Your immediate physiological priority shifts.
You don't just blindly massage it.
No. Massaging a displaced uterus that is resting on top of a massive, rock-hard bladder is not only excruciatingly painful for the patient, it is clinically ineffective.
Yeah.
You are fighting against a physical barrier. You must empty the bladder first, allow the uterus to drop back into the midline, and then massage it.
But assessing bladder fullness can be incredibly tricky. A patient might tell you they're using the restroom frequently, but we have to look out for the phenomenon of retention with overflow.
This is a classic presentation that masks severe retention, and instructors love testing this. A patient voids frequently, but they're only passing 50 to 100 milliliters at a time. The assumption is that their kidneys are just trickling output.
But that's a trap.
A huge trap. The reality is that the bladder is distended to its absolute maximum capacity, perhaps holding a liter or more of urine, and the sheer internal pressure is forcing a small amount of urine to spill over the top and out through the urethra. The bladder isn't actively emptying, it's just overflowing.
How do we intervene physiologically to bypass this?
We use non-invasive sensory stimulation first. Running water in the sink or using a peri-bottle to pour warm water over the perineum can help relax the urethral sphincter and trigger the voiding reflex.
And if that doesn't work?
If the edema is too severe or the anesthesia hasn't worn off and we can physically palpate a distended bladder above the pubic bone, we have to intervene mechanically. Intermittent straight catheterization becomes necessary to physically drain the fluid and protect the uterus.
Got it. Now, while the kidneys are in overdrive, the gastrointestinal system is effectively doing the exact opposite. It just grinds to a halt.
Yeah, the GI tract is sluggish for several compounding reasons. The lingering effects of pregnancy progesterone, which relaxes smooth muscle, are still present. The patient was likely NPO during a prolonged labor, so there's nothing in the tract to move. Plus, they may have received opioid analgesics, which severely depress peristalsis.
But there's also a massive psychological component to this that manifests as a physical barrier.
Absolutely. The visceral fear of pain. If a patient has an episiotomy, a severe perineal laceration, or engorged hemorrhoids from pushing, the psychological terror of having their first bowel movement causes them to subconsciously clench and withhold, overriding whatever sluggish peristaltic urge they might have.
Which just makes the constipation worse.
Right, and the subsequent straining can literally tear apart their delicate perineal surgical repairs. Proactively anticipating this fear and providing scheduled stool softeners is a vital safety intervention.
So we've mapped out the pelvic floor and the cardiovascular system. Now I want to shift our focus upward to the profound physiological changes happening in the breasts, because the body is executing another incredible pivot here. It is transitioning its entire energy output from internally gestating a human to externally feeding a human.
The endocrine shift required to establish lactation is a beautifully complex cascade. During the pregnancy, the body has extremely high circulating levels of estrogen and progesterone. These hormones are responsible for the massive structural growth of the breast tissue. They build the ductal network and the alveolar milk-producing cells.
But crucially, these same hormones act as a brake pedal, right? They actively inhibit the actual secretion of milk.
So the factory is fully built and staffed, but the power is turned off.
Exactly. The trigger to turn the power on is the delivery of the placenta. The moment the placenta leaves the body, the source of that massive estrogen and progesterone supply is gone. Their levels plummet instantly. This abrupt withdrawal removes the brake pedal, which frees the anterior pituitary gland to release prolactin.
Prolactin is the architect of the milk itself. It synthesizes the fluid.
Yes, prolactin binds to the receptors on the alveolar cells and instructs them to begin pulling water, proteins, carbohydrates, and lipids from the maternal bloodstream to synthesize breast milk.
But prolactin only makes the milk. It doesn't deliver it. That requires the other half of the dynamic duo, oxytocin.
Oxytocin is released from the posterior pituitary gland, primarily in response to mechanical stimulation, like the infant suckling at the breast. Oxytocin travels to the breasts and targets the myoepithelial cells, which are essentially tiny bands of smooth muscle that surround the alveoli.
Ah, so it acts like a pump.
When oxytocin binds to them, these bands contract, violently squeezing the alveoli and forcing the milk out into the ductal system and toward the nipple. This is the physiological mechanism of the letdown reflex.
And the timeline of this production is carefully staged. The newborn doesn't need a massive volume of fluid on day one. Their stomach is the size of a marble.
Which is why the early milk, colostrum, is so highly concentrated. Colostrum is a thick yellowish fluid that is exceptionally rich in protein, fat-soluble vitamins, and vital immunoglobulins like IgA, which coats the infant's gut to provide passive immunity. It is low in fat and carbohydrates compared to mature milk.
And when does the mature milk come in?
The true mature breast milk, which is thinner and bluish-white, typically doesn't transition in until 4 to 5 days postpartum as the prolactin levels fully take over.
This timeline brings us to a major clinical reality: engorgement. And managing engorgement requires us to understand two completely diametrically opposed physiological pathways, depending on whether the patient intends to breastfeed or formula feed. If we apply the wrong intervention, we can cause excruciating pain or severe tissue damage.
Primary engorgement happens around day 3 to 5. It's not just the breast filling with milk, it's a massive vascular response. The blood vessels and lymphatic system in the breast dilate and swell as they rush supplies to the alveoli to support lactation. The breasts become bilaterally heavy, hard, hot, and intensely tender.
So if a patient is actively breastfeeding and experiencing this painful vascular swelling, what is the physiological intervention?
For the breastfeeding patient, the ultimate goal is to facilitate flow and empty the breast. To do this, we need to manipulate the letdown reflex. Before the patient feeds the infant, we apply heat. A warm compress or a warm shower causes vasodilation, increasing blood flow, and the warmth itself stimulates the neuroendocrine release of oxytocin, triggering letdown. This softens the areola, allowing the baby to latch properly and empty the milk.
And after the feeding is complete,
once the milk is emptied, we need to manage the vascular inflammation, so we switch to cold. Ice packs applied after a feeding cause vasoconstriction, reducing the blood flow and lymphatic swelling, which numbs the tissue and provides pain relief without inhibiting the next production cycle.
Now let's look at the exact opposite scenario. A patient who is formula feeding and wants to completely suppress lactation. Their body is still experiencing the exact same prolactin surge and vascular engorgement, but our goal is to shut the factory down.
This requires absolute, strict physiological suppression. We must avoid any action that could trigger oxytocin or prolactin release. That means zero mechanical stimulation of the breast. No pumping, no expressing ill milk for comfort, not even letting the warm water of a shower run directly over the chest. Mechanical stimulation sends a signal to the brain that demand exists, and the brain will produce more supply.
So how do we treat the extreme pain of the engorgement if they can't empty the fluid?
We rely entirely on continuous aggressive vasoconstriction and physical containment. The patient must wear a firm, highly supportive bra 24 hours a day to compress the tissue and prevent stretching of the Cooper's ligaments. And we use cold therapy exclusively. Ice packs applied for 15 to 20 minutes every other hour restrict the blood flow, limit the vascular swelling, and signal the body that the area does not require increased perfusion. We are effectively freezing the factory out until the anterior pituitary recognizes the lack of demand and stops producing prolactin.
This is a classic area where well-meaning advice causes harm. Applying a warm compress to a non-breastfeeding mother's engorged breasts might sound comforting, but physiologically, it is disastrous. It stimulates vasodilation, brings more blood to the site, triggers oxytocin, and exacerbates the swelling and milk production.
It prolongs their agony by days or weeks. But we also have to distinguish normal vascular engorgement from infectious pathology because they can present similarly to an untrained eye. This is a critical differential diagnosis for exams.
We're talking about differentiating engorgement from mastitis or from a plug duct. Let's break down the pathology of each.
Engorgement, as we said, is a systemic bilateral vascular response. It happens gradually as the milk comes in, both breasts swell equally, the swelling is generalized across the entire breast, and crucially, while the patient is uncomfortable, they do not have systemic signs of illness. There is no fever.
Right. Mastitis, on the other hand, is an active bacterial infection of the interlobular connective tissue, usually caused by Staphylococcus aureus entering through a microscopic fissure in the nipple. Its presentation is starkly different. It hits suddenly. It is unilateral, almost always isolated to one specific breast. The pain is not generalized. It is localized to a specific, hard, red, incredibly hot wedge of tissue. And most importantly, the patient feels profoundly systemically ill. They present with severe flu-like symptoms, body aches, chills, and a high fever.
And a plug duct falls somewhere in the middle of those two.
A plug duct is a mechanical obstruction. A milk duct fails to empty properly, and the milk behind the plug backs up and thickens. Like mastitis, it is unilateral and localized to one specific tender lump. But unlike mastitis, there is no bacterial invasion. The patient feels generally well, and there is absolutely no fever. Treating a plugged duct involved aggressive massage, heat, and frequent feeding on the affected side to physically dislodge the thickened milk.
So we've secured the physical systems, the uterus, the cardiovascular fluid shifts, the urinary tract, and the endocrine mechanics of the breasts. But discharging a patient isn't just about ensuring they won't physically bleed. We have to look at the psychological and immunological foundation we're sending them home with.
The psychological shift required to integrate a newborn into a family structure is just as massive as the physical fluid shifts. We conceptualize this using Reva Rubin's maternal role framework, which outlines the incredibly specific, predictable cognitive phases a birthing parent navigates.
Let's explore the first phase, because it often conflicts with societal expectations of how a new parent should act.
Phase 1 is the taking in phase, and it dominates the first 24 to 48 hours. Society expects a new mother to be instantly focused on nothing but the baby, managing every aspect of care with joyful energy. The biological reality is that the patient has just survived a massive trauma. In the taking in phase, the patient exhibits deeply dependent behavior. Their cognitive focus is entirely inward, driven by basic physiological survival. They are obsessed with their own need for sleep, food, and pain relief. They frequently defer the care of the infant to nurses or partners.
And there's a strong psychological need to talk about the birth process itself repeatedly.
Yes. They need to verbalize the labor experience over and over again to cognitively integrate the trauma and the reality of the event. It is a necessary processing phase. Attempting to force a patient in this phase to master complex newborn care tasks is futile. They simply do not have the cognitive bandwidth to absorb the education.
That transition to the next phase, the taking hold phase, is when the cognitive bandwidth suddenly opens up.
Exactly. Around day 2 or 3, the physiological exhaustion begins to clear, and the patient shifts into the taking hold phase. They transition from dependent to independent behavior. They want to regain control over their own bodily functions, and suddenly they become intensely, almost anxiously focused on mastering the care of the infant. They want to know exactly how to feed, how to bathe, how to decipher cries.
This is the optimal window for clinical education. If you want to teach a patient the mechanics of umbilical cord care, you do it during the taking hold phase when their brain is actively seeking that specific mastery and they are hungry for reassurance.
And eventually, usually after discharge, they enter the letting go phase. This is the long-term psychological restructuring. They let go of the fantasy of what the baby would be like and accept the reality of the infant they have. They let go of their previous identity as a non-parent or a parent of fewer children and actively negotiate their new role and relationships within the evolving family dynamic.
But this psychological restructuring isn't limited to the birthing parent. The literature is very clear that non-birthing partners undergo profound neuropsychological adaptations as well.
Yes, partners experience a deeply rooted phenomenon known as engrossment. It's not just happiness, it's a measurable, intense behavioral focus characterized by 7 specific traits. They develop an intense visual and tactile awareness of the newborn, an overwhelming desire to hold and inspect the infant, a perception that the newborn is uniquely perfect, and a profound sense of elation and increased self-esteem.
And they also navigate their own transition of roles, moving from the expectations they held during the pregnancy to confronting the harsh reality of sleep deprivation and constant demand, and finally transitioning to mastery, where they find their specific functional role in the family unit.
Recognizing this is critical because perinatal mood disorders do not discriminate. The physiological hormone crash the birthing parent experiences is intense. The rapid withdrawal of placental hormones triggers a massive neurological reset. This manifests universally as the baby blues.
The baby blues are a normal, expected physiological response, right? It's characterized by emotional lability, unexplained tearfulness, fatigue, and mild anxiety.
It is expected, yes. It typically peaks around days 4 or 5, coinciding perfectly with the arrival of the mature breast milk and the peak of physical exhaustion. And the critical defining feature is that it naturally resolves on its own by day 10 to 14 without pharmacological intervention.
But when that timeline extends, or the severity deepens, we cross the threshold into pathology.
When profound symptoms of sadness, apathy, intense guilt, or an absolute inability to care for oneself or the infant persist beyond that 2-week mark, we are looking at postpartum depression. And we must remember that up to 1 in 10 non-birthing partners also develop postpartum depression, often driven by the severe sleep deprivation and the overwhelming stress of the new reality.
And the most severe manifestation, postpartum psychosis, is an absolute psychiatric emergency.
Postpartum psychosis is rare, but it is lethal. It involves a complete break from reality hallucinations, profound delusions often centered around the infant, severe agitation, and a high risk of infanticide or suicide. It requires immediate hospitalization.
So we are monitoring their psychological state, but there is one final purely immunological safety check we have to perform before a patient can safely leave the facility. And this isn't about protecting the current baby. It's about ensuring the survival of future generations. I'm talking about Rh sensitization.
The biology of the Rh factor is fascinating and ruthless. If a birthing parent has Rh-negative blood, it means their red blood cells lack a specific protein marker. If the baby they are gestating has Rh-positive blood inherited from the other parent, we have a biological conflict. During the pregnancy, and especially during the trauma of birth, microscopic amounts of the baby's Rh-positive blood inevitably cross the placenta and enter the maternal bloodstream.
And the maternal immune system sees those Rh-positive cells as foreign invaders.
Exactly. The maternal immune system immediately begins manufacturing permanent antibodies to seek out and destroy Rh-positive blood. This is called sensitization. Now, this doesn't harm the current baby because they are already born, but if that parent ever gets pregnant again with another Rh-positive fetus, those maternal antibodies will cross the placenta, attack the fetus's red blood cells, and cause severe, often fatal, hemolytic disease of the newborn.
It essentially turns the maternal immune system into a weapon against future pregnancies. So how do we stop the immune system from building those weapons?
We use Rh-immune globulin, or RHIG. If we have an Rh-negative mother who gives birth to an Rh-positive baby, we must administer an intramuscular injection of 300 micrograms of RHIG within 72 hours of birth. The RHIG acts like a stealth team. It floods the maternal bloodstream, locates the microscopic fetal Rh-positive cells that crossed over, and destroys them before the maternal immune system even notices they are there. Because the immune system never sees the foreign cells, it never builds the permanent antibodies.
It is a brilliant, highly time-sensitive intervention. If you miss that 72-hour window, the immune system locks in and the sensitization is permanent.
Which perfectly highlights why postpartum care is such a high-stakes environment. You are managing the immediate physical recovery, the psychological transition, and the long-term immunological health of the patient simultaneously.
As we wrap up this incredibly deep dive into the puerperium, I want to distill this massive volume of physiology down to the absolute core clinical priorities. If you're walking onto a postpartum unit tomorrow, these are the mechanisms you must have locked in your brain. Let's do the final 5.
Number 1 is always the fundus. Uterine atony is the primary driver of hemorrhage. You must assess for a firm midline uterus. If it is boggy, your immediate reflexive action is by manual massage to mechanically force the muscle to contract. If it is displaced laterally, you must recognize the anatomical barrier of a distended bladder and empty it before the uterus can effectively contract.
Number 2 is the cardiovascular reality of tachycardia. The body's first response to volume loss is to increase the heart rate. Do not dismiss a pulse over 100 as pain or anxiety. In the postpartum period, tachycardia is a blaring alarm for hypovolemia and hidden hemorrhage. Investigate it aggressively before the blood pressure has a chance to drop.
Number 3, understand the strict progression of lochia. The internal healing of the placental site dictates a shift from rubra to serosa to alba. Any reversal of this process, a return to bright red bleeding after the initial phase has passed, indicates a breakdown of the hemostatic seal and requires immediate medical evaluation.
Number 4 is mastering the differential diagnosis of the breasts. Recognizing the systemic vascular swelling of normal engorgement versus the localized infectious pathology of mastitis is critical. And remembering the physiological diametric opposites of care. Heat and vasodilation to facilitate breastfeeding, strict cold and vasoconstriction to suppress it.
And finally, number 5, timing is everything. You have a rigid 72-hour window to administer Rh immune globulin to prevent permanent sensitization. You must time your patient education to match their cognitive transition into the taking hold phase, and you must monitor the psychological timeline, expecting the baby blues to resolve by day 14, and recognizing anything beyond that as pathological depression.
We've spent this time unraveling how the body frantically and miraculously reconstructs itself in the span of 6 weeks. We've explored the cellular catabolism, the massive fluid offloading, the neuroendocrine shifts of lactation, and the psychological restructuring. But I want to leave you with a thought that expands far beyond this immediate recovery window.
Yeah, let's hear it.
When you look at the emerging research from advanced practice nurses and reproductive endocrinologists, they are increasingly tracing the trajectory of a patient's health in their 50s and 60s directly back to how their 4th trimester was managed. The structural integrity of the pelvic floor, if not properly rehabilitated after the trauma of birth, dictates continence and mobility decades later. The subtle, untreated perinatal mood disorders can permanently alter neurochemical baselines, influencing mental health resilience through menopause. The vascular stress of preeclampsia leaves a permanent footprint on long-term cardiovascular risk.
Wow, that really changes the perspective.
It raises a profound clinical perspective. When you are managing the fluid shifts, the fundal checks, and the emotional ability of a patient 2 days after birth, you aren't just treating a temporary state. The precision of your care in that narrow, volatile window is actively laying down the physiological and psychological foundation for the entire rest of that patient's life. Think about the gravity of that long-term impact the next time you walk into a postpartum room. See you next time on The Deep Dive.